Great, none other than my friend and my inspiration also for weight loss, Dr. Shubham Vatsya. Of late, he has been my favorite gastroenterologist. Whenever I find a chance, I refer my patient to him for any procedure. So, since he is one of us, so I need not go into details of his introduction. The first line is, he is one of us. Secondly, he is alumni of UCMS. He did MD in medicine from Mulanaja, then DM, gastroenterology, and lot of experience at Jodhpur Medical College. He is experienced for more than 10 years in the field of gastroenterology. His main area of interest is advanced endoscopy. The routine endoscopy everybody does. So he is into advanced like ERCP, EUS, hepatopancreatic biliary system and motility disorders, IBD. And he has performed more than 1,000 ERCPs and 1 lakh endoscopies. Income tax वालों को कोई एतराज नहीं होगा. So I'm not going into details of his achievements in this field in scientific and other era. Firstly, about the topic. डॉक्टर चौहान होते तो वो गा के सुना देते सीने में जलन आँख में तूफान सा क्यों. तो जो सीने में जलन का जो फर्स्ट लाइन है दिस draws our attention towards GERD, the gastroesophageal reflux disease. So it can be simple, just like anybody has it. I don't think anybody will claim that I have never had GERD. We have it at times, but if it is bothersome, as a routine, needs treatment. And there are some red flags when we must direct our patient to Dr. Vatsya. If a person is having anemia, weight loss, has a past history of peptic ulcer, or bleeding, not improving, then we must refer him to Dr. Vatsya for further investigation and management. So I invite him to give us updates on newer developments also and routine treatment.
Dr. Kalra sir ने कहा कि सीने में जलन. There is a very famous शेर from Gerd and it was told to us by Dr. G.D. Gupta sir, who used to teach us in Gopalnagar. So he has described this peptic ulcer pain as जिगर के दाग जले जिगर के लिए, जिगर के दाग जले जिगर के लिए वही चिराग बने बेचिराग घर के लिए. So this is a kind of ulcer pain that was described by Gerd. There was continuous pain at night and there was no relief, and that was the only hope, that was the only chirag for the poor people, you know. So I'm sure Dr. Shubham would go into details of GERD and would tell us how to get relief from this terrible disease.
A very good evening to all of you, and as so sweetly introduced by Chauhan sir and Kalra sir, I would like to just remind Chauhan sir that I met him for the first time around 7 years ago at Eros, when it was a CME of Dr. Viveka, and I recognized Renu ma'am because I was a student at UCMS. So that was the first time I met him, and he invited me here, and we met for the first time at PFI here. So I've been a regular with you every Wednesday since the last 7 years, and I think I've got a lot of love in return, which I'm very thankful to each and every one of you that I'm so good friends with you. Talking about the topic, so GERD was taken mainly because it is something which we see every day, and very few cases are actually required to be seen by a super specialist, right? The working diagnosis is always made by, as Sir just told, by the functional complaint, the functioning complaint, not a functional complaint, but a functioning complaint of the patient of retrosternal burning or jalan, right? Mostly patients respond to PPI. the problem arises when, rightly said by Kalra sir, when they have a red flag. So there are classical 4 red flags: dysphagia, anemia, weight loss, unintentional weight loss, and GIBD. So these are the 4 things which actually require an endoscopy. Otherwise, these patients do not require an endoscopy, right? The 5th class of patients which would require an endoscopy for a physician, which is important, is that you have given a double dose of PPI, like 40 milligram BD dose of pantoprazole or esomeprazole double dose, and still the patient is not responding in 12 weeks. So that means that this patient has something which is not typical. So if we have to understand as like a physician, अगर मैं मतलब आपसे बात कर रहा हूँ over a drink or over a coffee या meeting में, तो इसका मतलब है या तो एसिड नहीं है, या तो कुछ और है, या फिर इतना एसिड है जो इंजरी कर चुका है. हम क्लियर है? आई अंडरस्टैंडिंग? क्योंकि एसोमेप्राजोल या पेंटोप्राजोल एसिड को तो मार देता है ना. तो अगर मैक्सिमम डोज में भी 12 हफ्ते में वो रिस्पॉन्ड नहीं कर रहा है, तो मतलब या तो जो कल्प्रिट है वो एसिड नहीं है, या फिर एसिड इंजरी कर चुका है, मतलब इरोसिव रिफ्लक्स डिजीज हो चुकी है. So that is how we classify GERD as erosive reflux disease or non-erosive reflux disease. तो अगर इरोजन नहीं है तो मतलब वो रिस्पॉन्ड कर देना चाहिए था. इरोजन से पेन और जलन है तो वो रिस्पॉन्ड नहीं कर रहा है. तो सबसे पहले एक बात आती है कि सपोज जो रिफ्लक्स कर रहा है वो एसिड नहीं है, तो क्या पॉसिबिलिटी है? 2 पॉसिबिलिटी हैं. एक लिक्विड रिफ्लक्स है विच इज नॉन एसिडिक, मतलब बाइल है, और दूसरा है कि वो हवा है, राइट? तो डायग्नोसिस बदल गया है यहाँ पे. अगर वो हवा है तो डायग्नोसिस क्या है? नाउ दैट इज क्लासिकल कॉल्ड अ फंक्शनल हार्टबर्न और अ फंक्शनल डिस्पेप्सिया, राइट? ये पेशेंट को हवा आ रही है, सिम्टम आ रहा है, पर पीपीआई को रिस्पॉन्ड नहीं कर रहा, राइट? एंड द सेकंड वन इज कि वो एसिड जो है, वो रिफ्लक्स जो है वो एसिडिक नहीं है, तभी वो पीपीआई को रिस्पॉन्ड नहीं कर रहा. So this is the basic baseline which I think is the take home message of tonight, which I think the physicians will understand what I am saying. Coming to very basics, right? I will talk very basic. So one of the most common diagnoses made by primary care physicians and gastroenterologists is GERD. The Moderator classification defines as heartburns or complications resulting from reflux of gastric contents into the esophagus, up to the oral cavity and or lungs. So this is very important to understand that GERD is something which a lot of people have. So it is called the GERD iceberg, that majority of the patients with mild symptoms do not meet any doctor. Patients with frequent symptoms, they meet the primary care physician, and patients with chronic persistent symptoms like 12 weeks not responding to BPI or complications like red flags of dysphagia, anemia, weight loss, GIBD are seen by gastroenterologists, right? So it is classically defined into 2 groups: the non-erosive reflux disease (NERD) and the erosive reflux disease. So heartburn symptoms but without endoscopy evidence of mucosal erosions is NERD, and heartburn symptoms accompanied by objective erosions of is known as ERD or erosive reflux disease. So I have told you about this. So already we are on the same page. So functional heartburn का मतलब है heartburn है पर acid नहीं है, हवा है. So that is functional heartburn or functional dyspepsia. These patients are classical patients you see in the OPD who are stressed, who are overthinkers, newly married females, सास बहू कलेश, उसको जलन हो रही है, stress not coming out, anxious patients, anxiety disorders, depression. This is the classical patients who present like this. This is the class of patients who respond to SSRIs. These are the class of patients who respond to benzodiazepines and methadone, right? So this is very important to understand that these class of patients do exist. They are at least 50% of the total patients in the OPD who present with symptoms of heartburn, right? So in ambulatory settings, GERD accounts for 17.5% all over the world. In India, I think it is a little more. And there are recent studies which show that 1/4 all over the world in every area, 1/4 population suffers from GERD, right? So cardinal symptoms, so very classical: trouble, heartburn, regurgitation, reflux of acidic material, non-acidic material sometimes presenting with heartburn. So another thing which is very classical, the pulmonologists will agree, is when reflux happens into the pharynx or into the lungs. They comprise of the extraesophageal or the atypical manifestations of wheezing, cough, laryngitis, dental erosions, asthma, right? So a lot of people say kadwa pani muh mein aana, like water brash, hypersalivation or painful swallowing is not still proven to be directly related to GERD, right? So Again, what are the pathophysiology? They can be physiological and pathological risk factors. Physiologic reflux क्या होता है? अगर क्लासिकली बात करें तो जो हिकअप होता है या ढकाव होता है, transient lower esophageal sphincter relaxation post meal is known as a physiological reflux. It is transient, does not occur in sleep and does not result in reflux symptoms. Okay. So pathophysiological reflux. So this is again classical. So you remember that the G junction, right, has a functional sphincter. It is a functional, not an anatomical sphincter, known as the lower esophageal sphincter. It is supported by the most strongest muscle, strongest smooth muscle in the body, known as the diaphragm. So when as we age, the diaphragm muscle weakens. So diaphragm pulls the LES and keeps it in the position, right? The opening of the esophagus into the stomach is known as the hiatus. Hiatus means opening, right? So when with age or with multiple factors there is smooth muscle weakness of the diaphragm, the pull of the LES goes away. So that when the pull goes away, the most common thing comes up, which is called as the hiatus hernia. Yes, very correct. So I think I am making sense. People are listening. So that is hiatus hernia. So when the herniation of the normal side of the LES above is the hiatus hernia. Now that the physiological sphincter has lost its maximum support. So that is why patient is having reflux. So the reflux increases, that is the hiatal hernia, which is most commonly found in these patients. So risk factors, again, abdominal obesity, very common, medications, diet, lifestyle, smoking, alcohol, infiltrative disorders, these are the most common things, but practically obesity accounts for 50 to 70% patients of reflux, and 15% of these obese patients also have hiatus hernia, like we were talking about. So there are some medications, not important, not common, so but for the sake of completion, anticholinergics, smooth muscle relaxants, aminophyllines, nitrates, calcium channel blockers, phosphodiesterase inhibitors can cause pathological reflux. So yes, so this is important. This is where actually a super specialist comes into the picture. These are the complications. Classical one, esophagitis, peptic stricture, Barrett's esophagus. So Barrett's esophagus is very important. It is the most strongest pre-malignant risk factor for adenocarcinoma of the esophagus. So we'll have to understand that India is a developing country and the geography is very different from the West. So if we read Harrison, if we read Schlesinger, textbook of gastroenterology, the most common malignancy in the West is adenocarcinoma. In India, it is not adenocarcinoma. Adenocarcinoma is coming up with the urbanization and change in lifestyle. So what is happening is the most common malignancy of esophagus in India still is the squamous cell carcinoma, which happens in the middle one-third, right? It has poor prognosis. Adenocarcinoma compared to squamous cell carcinoma has a better prognosis, and GERD is the precursor of adenocarcinoma. So if you see the higher socioeconomic strata, adenocarcinoma is coming up, but still it is much less than the West. So why is adenocarcinoma coming up? Because uncontrolled GERD, which is leading to erosive reflux disease, which leads to esophagitis, then peptic strictures, Barrett's esophagus. So this is the natural history of the disease. So our aim is actually to prevent the major complication of GERD. As a super specialist, my aim would be to prevent adenocarcinoma of the esophagus. So how can I do that? I can recognize Barrett's esophagus. I can recognize erosive reflux disease. So that is where my role comes in, right? So esophagitis, again, this is not very important for us to understand right now. We are not gastroenterologists. The Los Angeles classification is an endoscopic classification, where if it is less than 5 mm break, it is class A, more than 5 mm break, not particular, it is B. C is continuous erosions and D is again Barrett's esophagus, which is luminal, but not important for us. Peptic stricture, remember, it is the most common cause of benign esophageal stricture. There are other causes which are not as common, like eosinophilic esophagitis, corrosive ingestion. So these are the three. If somebody asks me in a DM exam, what are the three common causes of esophageal benign stricture? So the most common is peptic stricture, corrosive ingestion, and followed by eosinophilic esophagitis. But this is the most common one. It responds very good to endoscopic dilatation. Patient does not even require second setting. So if these patients are caught early, dilated, biopsied, identified with Barrett's esophagus, we can save lives, right? So Barrett's esophagus, as I told you, it is intestinal metaplasia of the distal esophagus. So esophagus is squamous cell epithelium, stomach is columnar epithelium. So when you see columnar epithelium in the esophagus with intestinal goblet cells, it is called Barrett's esophagus. So again, we are not interested in medical or gastroenterology here because this is something which is beyond the level of internal medicine. So yes. So diagnosis. When patients with typical symptoms of heartburn regurgitation, no diagnostic tests are necessary. So diagnostic tests are necessary in 5 conditions which I have told you. 4 red flags: dysphagia, anemia, weight loss, GI bleed, and non-response to 12 weeks of maximum PPI therapy. Right? So diagnostic tests include barium swallow, endoscopy, ambulatory pH monitoring, and esophageal manometry. So the last 2 tests are very important for us to understand that physicians की करते क्यों हैं. ये किए जाते हैं उन पेशेंट्स में जिनको सर्जरी ऑफर करते हैं. ठीक है? उसका कारण है कि सर्जरी आपने ऑफर करी तो आप बचा रहे हैं एसिड रिफ्लक्स. इसोफेजियल पीएच मॉनिटरिंग आपको बताइए कि ये एसिड है, ये नॉन एसिड है, ये हवा है. अगर जिसको हवा आ रही है, जो फंक्शनल डिस्पेप्सिया वाला पेशेंट है, उसको हमने सर्जरी कर दी, उसको रिस्पॉन्स नहीं आएगा, वो हमारे पीछे पड़ जाएगा कि डॉक्टर साहब सर्जरी भी करा दी, रिस्पॉन्स भी नहीं आया. मैनोमेट्री जरूरी है क्योंकि GERD is associated with hypomotility of the esophagus. So if you don't do a manometry and patient has subtle achalasia cardia or hypomotility non-classified, then again the patient will not respond to fundoplication or endoscopic therapy. So these 2 things become very important in a pre-surgical case. अगर सर्जरी नहीं करानी तो इन दोनों का मोटा-मोटा कोई काम नहीं है. So barium swallow becomes the first test. Endoscopy, again I told you, it is helpful for detection of Barrett's esophagus, preoperative evaluation, treatment failure, alarm symptoms. Right? So we are repeating the same thing. Again, see what are we doing? We are actually monitoring. So we are putting a probe in the esophagus and we are looking for reflux. And when it refluxes, तो ये जो मशीन है इसके वेस्ट पे पेशेंट एक बटन दबाता है. तो अगले जब हम कंप्यूटर पे पढ़ते हैं तो दिखता है जब बटन दबाया था उसे रिफ्लक्स फील हुआ था तो पीएच फॉल हुआ था कि नहीं हुआ था. मतलब हम देख रहे हैं सिम्टम एसिड की वजह से है कि नहीं है. राइट? सो दिस इज व्हाट दिस हैपेंस if you see this. So this is the pH less than 4. So normal is very few in the night, but overnight if you see when the patient is lying down, you have maximum acidity in the lower esophagus and the esophagus. So this is the ambulatory pH monitoring. So this is again the advances which we have today. It's like a pencil. So these are wireless catheter-free esophageal pH monitoring. These are advanced, expensive things which we can do to patients who do not want a probe in their going through their nose or their mouth into the esophagus. You can place it endoscopically. You can leave it there. You can tie it to the lower esophagus, and the patient with the Bluetooth has a again machine on the waist where he can press whenever he has symptoms. Right. So these are again the recent advances in diagnostic testing. They are immunohistochemical markers, multi-channel intraluminal impedance pH monitoring, and narrowband imaging. So again, there are some markers which are under research. These markers like proteinase, active receptor, and interleukin 33, GPCR84, TREM1 still are under research and do not have any. It continues to evolve. Still, it is not established. So this is again a very advanced thing where this is mainly for patients who show reflux, which is non-acidic. So this is to detect bile. So if you see. This is a multi-channel intraluminal impedance pH monitoring. So as it was 24-hour pH monitoring, there was only one channel. Here there are multiple channels, and this is to determine the extent of reflux and the non-acidic reflux, right? So this is mainly for non-acidic reflux and extent of reflux. So these are multiple channels throughout the length of esophagus. So narrowband imaging. So what is narrowband imaging? So the white light endoscopy. So if we understand the white light is made up of 7 colors with pure violet, indigo, blue, yellow, orange, red, right? Narrowband throws light at 2 wavelengths, which is 400 nanometers and 530 nanometers. These 2 wavelengths are for the blue and green. So if you see the blue and green is the color which is absorbed maximum by red. So what are we looking for? We are looking for early bleeding changes or early changes to blood vessels. So narrowband imaging at 400 nanometer and 530 nanometer helps at detecting the intracapillary loop dilatation, microerosion and vascularity prominence. So जहाँ blood ज़्यादा आएगा, narrowband imaging हमें help करेगी जल्दी पकड़ने में. So narrowband imaging is actually seen on a normal endoscope. We have a button which when we press, it gives us narrowband imaging. Okay, so this is again a very advanced thing which is only done in one center all over India. This is the endo-functional luminal image probing system. It is done in AIG Hyderabad, and this is for dynamic measurement of gastroesophageal distensibility. So this is pre-op done for patients who are going to get operated for GERD. This also has a role in patients of achalasia cardia, and this is not available anywhere else. Done for research purposes at AIG. So what are the treatment goals? Treatment goals are very obvious, right? All of us want to eliminate symptoms, to heal esophagitis, prevent complications and maintain a healthy patient. तो यहाँ तक तो हम सारे समझ रहे हैं GERD पेशेंट को हमें सिम्टम फ्री रखना है, डिजीज फ्री रखना है, esophagitis फ्री रखना है, उसका डिस्फेजिया, अनीमिया, वेट लॉस, GI bleed बचानी है और उसको रिमिशन में मेंटेन करना है. So these are the 4 things which we have. The non-pharmacological methods हमें हर किसी को पता है. मोस्ट कॉमन रिस्क फैक्टर ओबेसिटी है, अल्कोहल है, स्मोकिंग है. हमें अल्कोहल रोकनी है, स्मोकिंग रोकनी है और वेट लॉस करवाना है. जैसे सर कहते हैं मैंने वेट लॉस कर लिया, मुझे लगता है मुझे और ज़रूरत है, बट मेरे को GERD सिम्टम्स नहीं थे, सो स्टिल आई वांटेड टू लूज वेट. सो नॉन फार्माकोलॉजिकल ये 3 चीज़ें हैं. फार्माकोलॉजिकल हम सबको पता है, PPIs आर द कॉर्नरस्टोन ऑफ थेरेपी. सोमप्राज इज द बेस्ट PPI, राइट? एंड सर राकेश सर आपके लिए Sompra is the best PPI, and now we have advances like PCAPs, the potassium channel blockers. I've already taken a CME with Tulsi sir in the same group for that. Vonoprazan is another very good drug. The H2 receptor antagonists are not as effective. One group of drugs which we definitely should talk always are alginates. Alginates, sodium alginate जो आते हैं राफ्ट करके काफी कंपनीज के हैं. They actually put a coating on the gastric acid. तो जब वो रिफ्लक्स होता है तो गैस्ट्रिक एसिड और इसोफेगस के बीच में एक राफ्ट बन जाती है. ये उसका एम है, मतलब आप हमारे दिमाग में बिठाने के लिए कि वो राफ्ट क्रिएट करता है. तो इट इज गुड फॉर पोस्ट प्रेंडियल रिफ्लक्स, राइट? ये खाना खाया, उसके बाद जो रिफ्लक्स हो रहा है तो उस खाने और एसिड के बीच में वो राफ्ट आ गया, सोडियम एल्जिनेट की राफ्ट आ गई, जिसने फूड पाइप से मिलने से बचाया. एंडोस्कोपिक मेथड्स आर क्लासिकली नोन एज टिप. दीज आर ट्रांसइसोफेजियल इंसिशनलेस पंडोप्लाइकेशन मेथड्स. इसमें 3-4 मेथड आते हैं, म्यूज सिस्टम, स्ट्रेटा सिस्टम, गर्डेड सिस्टम. These are advanced methods done for patients who are either not fit for surgery or they don't want to get surgery, right? They are expensive methods, but done at few centers in India, but yes, done, effective, and still they are evolving. And surgical methods, the classical fundoplications which are done, right? The laparoscopic fundoplications, some advances today, the laparoscopic magnetic augmentation of the lower esophageal sphincter known as the links procedure. So these are some things which are new, but आप और मैं फिजिशियन हैं, हम पेशेंट को PPI, PCAPs, alginates पे चाहते हैं फिक्स हो, नहीं हो 12 हफ्ते में उसकी एंडोस्कोपी कराइए, देखिए वो एरोसिव डिजीज है, उसे बैरेट्स है, कोई रेड फ्लैग है, जल्दी एंडोस्कोपी करके उसे मैनेज करके हम उसकी मेलिग्नेंसी बचा सकते हैं. So this is what we were talking about. Foods which cause GERD उसे अवॉइड करना है. कॉफी, चॉकलेट, स्पाइसी फूड्स, हाईली एसिडिक citrus fruits, fatty foods, avoid consumption of alcohol and tobacco. One of the most important modifications is to lose weight. Right? Patients who are obese, who have severe reflux, we ask them to elevate the bed end so that reflux does not happen. So lying in left lateral decubit is another way. Consumption of meals 2 to 3 hours before bedtime. Ask the patient to walk around before sleeping is very important, and to avoid very tight clothes. So BMI कम करने से definitely फर्क पड़ता है. It reduces GERD symptoms by a lot. Pharmacological interventions I've talked about in detail, right? We have the H2 receptor antagonists, the PPIs, the PPI combinations, the alginates, the endoscopic methods of esophagus, muse, and the surgical endostem or the links procedure. So there are few newer H2 receptor antagonists. We don't use them much. I'm not much in a mood to discuss them. So yeah, reversible PPIs. So you understand that what is the word reversible PPI means, because PPIs, पहली बात कोई भी प्रोटॉन पंप इनहिबिटर सीधा जाके पेट में काम नहीं करता है. प्रोटॉन पंप इनहिबिटर्स आर प्रोडक्ट्स, they are absorbed, they are enteric coated capsules, they are not tablets, enteric coated capsules which go into the duodenum. Duodenum से वो portal vein के through पहले liver में जाते हैं, active drug में form होते हैं, फिर circulation के through basolateral side of gastric उस पे आते हैं जब वो stimulate होते हैं channels, and then from the basolateral side they block the activated channels. So the blockage is irreversible. So there is a hope and research कि ऐसे reversible PCIs बना पाएं जो postprandial या fasting state में भी काम कर पाएं, पर अभी हमारे पास ऐसा कोई भी product नहीं है. These are the ones which we have talked about in detail at multiple CMEs. I have done a few. The PCABs are good because they act directly. जो मैं PPI के बारे में बता रहा हूँ ये उससे अलग है. ये directly gastric lumen में काम करता है. इसको activated channel नहीं चाहिए. ये H plus K plus ATPase का H plus को PPI ब्लॉक करता है, K plus को ब्लॉक करता है. क्योंकि इसको activated channel नहीं चाहिए तो जब भी आपको acidity हो आप SOS ले सकते हो. इसको भूखे पेट लेने की जरूरत नहीं है. आप खाना खाने के बाद ले सकते हैं. Vonoprazan 10 milligram is a good dose. It can be escalated to 20 milligram. Right? So now we have PCABs and but again we have multiple drugs which are under research. None of them is still approved for the treatment or established in treatment of GERD. So these are the similar research things. Right? Yeah, we have newer prokinetics. Again, they are still undergoing multiple studies, which would further tell us whether they are here to stay or not. Pregabalin is again a very good drug. It helps in patients who have more neuropathic kind of dyspeptic symptoms, right? And this is a summary of multiple drugs which are under research. With their side effects, but major time the take-home message is the 4 ones which I talked about. So surgery is classically indicated for patients who do not respond to optimal medical therapy, non-compliant patients, patient not willing to continue medical management, patient with side effects of medicine, patients with large hiatus hernia, patients with large volume reflux, patient with strictures, Barrett's esophagus, right? Barrett's esophagus classically who have severe dysplasia or malignancy, right? So most common, these are the classical surgical procedures which are available. So I think the classical ones are the Nissen fundoplication and the laparoscopic Nissen fundoplication, the open Nissen fundoplication, and these are the classical ones which are done by surgeons. Some new methods are there. I'll just touch upon them. This is one of them. This is the magnetic sphincter augmentation device which I talked about. The LINX procedure. It consists of a series of titanium beads with magnetic core connected to the titanium bias to form a ring. This ring is placed around the lower end of distal esophagus and it helps to augment through magnetic field to reinforce the lower esophageal sphincter. So this is the LINX reflux magnetic system. So this is the hiatus hernia, right? So उसके नीचे हम कोशिश कर रहे हैं नए वाला एक G junction create करने की with the LINX, right? So this is the laparoscopic implantation of electrodes in the lower esophagus, the endostomalius stimulation system. The electrodes are placed anteriorly on the esophagus and the generator is implanted on the abdominal wall, right? So this helps in decreasing the distal esophageal acid exposure, improving the quality of life of GERD, less use of PPI medication at the end of 3 years. So these are long-term therapies. So these are the multiple endoscopic therapies which have been tried, which are effective. Fixation, ablation, injection and mucosal excision and suturing, right? So again with an endoscope we can try to suture or ablate the gastric mucosa on the lower end of the lower esophageal sphincter to create a new lower esophageal sphincter to prevent the reflux, right? So this is what I was talking about. This is also known as transoral incisionless fundoplication. The esophagus strata in the Muse system. The esophagus tries to restore the anatomic lower esophageal sphincter through the endoscope. So it basically tries to suture. So here is the esophagus. It comes and it tries to suture this side to create a new lower esophageal sphincter. So if you see on an endoscope, when you retrovert the endoscope to see the fundus, in a hiatus hernia, this close association of the lower esophageal sphincter with the scope is not seen. This is loose, right? That is how we grade the hiatus hernia. It's known the Hill's classification. When you do the esophagus, it shows to be tight. So So it is a method endoscopically done, incisionless. So Strata system is again a balloon tip 4 needle catheter which delivers rate frequency energy like the electrode which we talked about, and it was first done in 2001. It has helped over 20,000 patients. Ultrasonic surgical stapler embedded with a custom endoscope. So here we do it with a endoscope with a surgical stapler. We can use the surgical stapler with knobs on the scope. So I'll just end my talk with the summary of whatever I've said. So heartburn and regurgitation without alarm symptoms. Alarm symptoms classically 4 होते हैं: dysphagia, anemia, GIT, weight loss. Symptoms with sufficient frequency and intensity of poor quality of life. Right? Patient सो नहीं पा रहा है, patient की personal life खराब हो रही है, patient काम नहीं कर पा रहा है, patient को socio-economic productivity hamper हो रही है. Right? 8 weeks, I would say 12 weeks is a better idea. Once before meal, PPI trial. Complete relief, discontinue PPI. So important to discontinue PPI. If symptoms recur, then you do an endoscopy of PPI. ये बहुत जरूरी है समझना. Endoscopy of PPI करते हैं. Of PPI क्यों? क्योंकि PPI अगर acid exposure कम कर देगा, तो हम erosive और non-erosive में differentiate नहीं कर पाएंगे. So we do off PPI, then we do the LA grading, the Barrett's, right? GRD confirmed normal. We do reflux monitoring of therapy. If it is abnormal, we confirm GRD. So the other thing is presence of extraesophageal symptoms, detailed medical history to identify adult initial causes, refer to other specialists for evaluation non-GRD. Typical GRD, PPI trial 12 weeks, extraesophageal symptoms improve, no improvement, reflux monitoring of PPI. तो जो improve नहीं कर रहे PPI को उनके PPI off करके हम उन्हें monitor करते हैं. And that's how I ended. Thank you so much.
Dear friends, you must agree it was one of the very elaborate and very nice talk, crisp talk, and I don't think he has missed anything which is new. Please come, sir.
Dr. Kalra, sir, with your permission, I would request Dr. Shubham Vatsya, our pediatric gastroenterologist, to please join us here. Dr. Shubham Vatsya is an eminent pediatric gastroenterologist. He goes to various hospitals. One of the eminent hospitals where he goes is Rainbow Children's Hospital. I have had the honor of mentoring Dr. Shubham Vatsya in Safdarjung Hospital, and he has been to various hospitals, including hospitals in London. I'm sure he would like to say a few words about the journey.
Thank you, Dr. Sushil, and thank you for inviting me to this event, and I'm a PFI member now. Association with you has gone back 38 years. When I was you were my mentor when I was an intern in Safdarjung Hospital, and my association with Shubham has been for more than 12 years now when we worked together at PSRI Hospital. The points I wanted to bring up were something very the difference between the theoretical guidelines and what we encounter in clinical practice, and I'm including both pediatric and adult. Now, we are looking at two aspects. I describe PPI left, right and center myself. I believe in them. They are the best agents for treating gastroesophageal reflux disease. But let's pause for a moment. When we look at the pediatric guidelines, because I'm a pediatric gastroenterologist, less than 2 years, the guidelines are crystal clear. It says don't start PPI till you're absolutely sure of the diagnosis. And the rationale behind that is, the first line of defense in your body against any infection is your skin and your respiratory cilia. The second line of defense is the chemical defense by hydrochloric acid and the gastric juice in the stomach. Why are you messing with that? And the peak age of incidence in gastroesophageal reflux is between 6 weeks to 9 months of age. At that age, if you're going to put a child on PPI, that child will definitely be more prone to gastrointestinal infections, and to suppress the gastrointestinal infections you give antibiotics. To handle the side effects of the antibiotics, you give a probiotic, and then one drug and another all follow, and there will be a mess up. So today we are in the era of prevention is better than cure. So the guidelines say please document a GERD less than 2 years of age. So if you're documenting a GERD less than 2 years of age, Endoscopy doesn't help you to document the GRD. If there's an erosion and the reflux esophagitis, it will help you. But for documenting, you need a pH study and an impedance. Because if there's an alkaline reflux, as Dr. Shubham mentioned, जहाँ acid की वजह से reflux नहीं हो रहा है, and that's about 20% of cases in pediatrics. That's a good number, 1/5 of cases. उसमें only impedance helps. How many centers in our private hospitals have pH studies and impedance? Hardly. So these are the guidelines. So the ground reality is, less than 2 years, 80% of our children are already on PPIs. So it's against the guidelines already, the practical reality. For the older children, more than 5 years, the guidelines are clear. If you strongly suspect as a clinician that this is a GERD, you will give empiric therapy for at least 8 weeks. And if it doesn't respond, you can think of other possibilities, which we do. But it's happening right from infancy. So my question is, when I was in the UK, at a time when Shubham might have been very young, 1996, Gaviscon Infant was something which was available because that's one of the most frequent alternates available in the market today. It's not available in the country. And sodium alginates are not licensed for use less than 12 years of age in India even today. It's a very effective agent because it forms a rough. It doesn't mess around with your acid. It prevents the stomach contents from coming into the esophagus. And that is what you want in this. So, if that doesn't work, for a few, again you have to have guidelines. Try that first. If that doesn't work, then you try your PPI. There's a clear evidence that PPI is better than ranitidine. There's absolutely no doubt about that. But why not try something which has minimal side effects, which is 100% safe in pregnancy, and is used in children, before trying the PPI?
Only fair to give Dr. Shubham Vatsya to respond. So I wanted Dr. Sharat Gopalan here just to give you the pediatric perspective, because we will not have that unless we involve it. And therefore, I would say that without Dr. Kalra's permission, I have involved him in the panel discussion because that gives us the pediatric perspective. Your take on that, Shubham. Is alginate not prescribed below 12 years of age?
No, sir, it's not recommended.
Okay.
That's point number one. But the thing is that why it is not recommended is still not clear. Because it is not absorbed into the blood and it forms a raft, as I said and Sir Mikey said. But I am more, sir, I have not seen a lot of pediatric GERD, to be very honest. Sir is much better in telling about that. We have used, we have genuinely used rafts, the alginates, left, right and center, in people who are not persistently responding to PPIs or are having post-prandial reflux. Because PPIs require the timing of the PPIs to be very, discrete. It has to reach the liver, activate into a product at the time you are eating food. Because it will not act on an unactivated H plus K plus ATPase. That has to be activated. So, a lot of people do not have that timing and we cannot calculate that very classically, which has been the major drawback of a PPI. So that is where the alginates for us come into the picture, that this patient maybe post drinking or post overeating has a lot of reflux. So that is where sodium alginate classically helps me. So for me, the mechanism of action is different. I would treat them differently. But yes, again, talking about PPIs, sir, I would add to your point. PPIs overprescription can lead to multiple side effects like iron deficiency, like calcium deficiency, like magnesium deficiency, like post-menopausal fractures, like SIPO, like Clostridium difficile. So yes, we should be looking for giving breaks to PPIs which go on for years, over the counters, people are eating Cascadevy, not responding to iron therapy, not responding to vitamin B12 injections, having fractures, having more DEXA scans post-menopausal which are falling. So yes, PPIs can be more notorious and people should be evaluated for drugs like alginates and all this, because this is somewhere where we cannot just, as a gastrologist, cannot ask you to close your eyes and give PPIs for 50 years non-stop.
I would like your take. You said that sometimes in Gerd you have to give PPIs twice. even at 12-hourly interval. Now, I want to know from you that what is there with the PPI is that you have to give them 12-hourly, and you mentioned about this drug, the new drug, the vonoprazan, which has to be given only once a day. So, is there a breakthrough acid secretion?
The nocturnal acid reflux is seen because of the breakthrough acid secretion, and it is classically seen with the change in the acid secretion over time, the diurnal variation to consistent PPI exposure. So we are trying to break that, the breakthrough acid reflux with a double dose, and to actually label it refractory GI. So more than the two things, one is to break the breakthrough acid reflux which is seen nocturnally in patients who have morning PPI, and second is to actually label these patients who require a super specialty care.
Now, I want to bring in Dr. Sarat Gopalan. Sir, you mentioned that actually GERD is very common in children, in infants actually. You mentioned about 9 weeks to
6 weeks to 9 months of age is the peak incidence of GERD any time during life.
What is the drug of choice? And do you want to treat that? Or
The guidelines, all the global guidelines mention PPI as the first line agent.
What is the dose? What is the dose in children?
See, we can go up to 1 milligram per kg and even up to 1.5. But you can start with a low dose of 0.8, 0.7, 0.8 and go up to 1.5.
How long do you give? How long do you give?
You can give it even as long, I mean PPI can go on for 6 months to 1 year if you want.
Only one question. We diagnose GERD clinically with patients having retrosal burning. What does the child say to diagnose GERD? I'm very
So in an infant, diagnosing GERD is purely by the basis of spit ups. So you really need to know if a child is spitting up. Dr. Chakrabarti is right here. He's my mentor in pediatrics, and Dr. Sehgal is also here. If a child is spitting up, is it actually spitting up because of GERD or anything else? You will say that better than anybody else.
Dr. Sharad and Dr. First of all, excellent talk by Dr. Vatsya, congratulations. As Dr. Sharad said, it's very difficult to really diagnose GERD in small infants. It's a diagnosis of exclusion. Most of the kids come to us, बच्चा दूध पीकर उल्टी कर देता है, what we call paucity or regurgitation, and it's overestimated. Almost all the children will regurgitate some amount. जैसे ना दूध फटा हुआ दूध निकाल देता है, normal है, कुछ amount तक. But it is a persistent thing, and at the same time, the child is not gaining weight. Then it clicks. Okay, it could be GERD, and then the treatment of GERD remains lansoprazole. We use left-to-right, lansoprazole tablet, 50 mg, 30 mg for bigger children, and the dose that you said 0.8 to 0.7, and we give it for 6 weeks time. But more than important than that is, I'll just take 2 minutes, is faulty feeding. Faulty feeding is the main culprit behind regurgitation, which we overdiagnose with GERD. आप बच्चे को लिटा के दूध पिला रहे हो, उसका सर नीचे है, आपका बच्चा दूध पीता है, ग्रेविटी में से दूध निकाल देता है, आप उसको GERD कह देते हो. The logic is, it should be 30-degree recline, and in between, if the child is paucity or regurgitation, you should break the feeding time into small breaks. What are called small feeding breaks. आपने 15 मिनट के दूध पिलाना है बच्चे को, उसको आप 5 भाग में तोड़ दीजिए. आपने 2-3 मिनट दूध पिलाया, हटा लिया, थोड़ा सा पैक कर दिया, फिर आपने दूध लगा के लैच कर दिया, फिर आपने 3 मिनट किया. तो you don't do a long feed in one go, the child will definitely regurgitate and you will say GERD हो गया. So small frequent feedings, proper feeding pattern, proper feeding decline will 99% solve the problem of regurgitation in kids. Some kids are difficult to treat. उनमें क्या होता है, बच्चे की माँ ओवरफीड करती रहती है, बच्चे का वो क्यों देता है, मेरे को दूध ही चाहिए, बच्चा कहता है पीती है, ये regurgitate. So these are small things which, but of course at the end of the day, EPN is the mainstay of our GERD treatment, but at the same time they have got wrong things also, like Dr. said. One of the things which came out recently was renal problems associated with PPIs. बहुत big common problem आई थी renal problems कि बच्चों को kidney problem हो रही है. I'll not take much of time.
So one last point before Dr. I invite Dr. Tulsi, his comment was very. Please be pediatric or adult patient. When you have a child or an adult presenting with pain or पेट में भारीपन है, gas है, please don't start off with PPI straight away. please get an X-ray abdomen done. You'll be surprised. बच्चों में 85% of cases, it's a loaded bowel with gas. Treat the constipation, treat the dysbiosis, and proton pump inhibitors, H2 receptor antagonists, antacids, alginates have absolutely no role in that situation. It's a constipation with gut dysbiosis. Similarly, in adults, we have seen numerous cases. So, you will agree. X-ray लीजिए, get a simple X-ray done, and you will see the constipation. Thank you. Dr.
Shubham, Dr. Chakraborty also mentioned about the renal side effects of PPIs. In your opinion, which of the PPI is safer, or all the PPIs are equally problematic on the kidney? There are reports with pantoprazole leading to acute kidney disease, and on a very long-term basis, because as you said, they have become the new aspirin and sorbitol of gastroenterology. Once on PPI, always on PPI. I have seen prescriptions from Sutherland Hospital for last 27 years. One patient is on PPI. Nobody has dared to change that prescription, and it happens most of the time in our daily practice also. So your take on PPI versus the kidney issue?
Interstitial nephritis is something which is actually coming up with PPIs, and a lot of idiopathic CKDs are now attributed to long-term PPI use. So that is definitely there. There are some studies which say that S-enantiomer of omeprazole, S-omeprazole is lesser associated with interstitial nephritis than the others. But still long-term use is not clearly very well established at how long-term with which PPI will cause interstitial nephritis or not. But yes, that is what the newer guidelines with ISG, Indian Society of Gastroenterology, and the emerging sites say that you should give drug holidays to PPI as well. Like it was done for tachyphylaxis with nitrates, as you say. So that is what is coming up. But yes, the S-enantiomer of S-omeprazole is considered to be safer in the kidney, but it is not very clear that how it is completely safe or not.
एक मिनट सर, मैंने सुना है मैं आज मॉडरेटर हूँ। और पहले तो आपने मेरे को ये कहा कि मैं 2.5 क्वेश्चन पूछता हूँ। सर I asked only half question. I asked only half question. सर, सवाल तो आपने इतने सारे पूछ लिए और अभी और पूछने वाले भी हैं। मैंने तो सिर्फ मॉडरेट करना था भाई। I'm just asking, when we start empirical therapy, as we say, without red flags, a person has come for heartburn and all that. So, what is your first choice? As you said, Somipraz is the best. Some people are using other brands. So, is it esomeprazole? It is a purer form of omeprazole, like we have S-adenosine and Metcure and all that. Is it a purer form? What is the...
Sir, academically, none of the PPIs has a major difference. I think any one of them can be used. With patients, I think cost should be considered the major thing.
My reference was to isomers. So, special isomers, R and L and S and D, is there any?
The major thing with S-omeprazole has been the nephrology side effects, and the other thing is the T half of different PPI is different.
Right.
So per se, my favorite has been Somipraz over the years and pantoprazole, pantocid, all these drugs. No major differences on practically would be seen if you use any one of the different drugs.
My last half question is, prokinetics, do we use in every patient or is it your gut feeling, isko dena hai, isko nahi dena hai, or you start first plain and then prokinetics? What is your take on it?
So the prokinetics are not major treatment for GERD, right? Prokinetics are treatment of mainly dyspepsia. So if you go to the Rome classification of functional dyspepsia, it is of 4 types. Type 1, type 2 is epigastric pain syndrome, and type 3, type 4 is PPDS, post-prandial distress syndrome. So prokinetics are the actual drugs which are used for patients who have post-prandial bloating. When we eat food, there is a receptive relaxation of the gastric fundus which stores the food for 4 hours, and then there is a process called trichulation which happens in the gastric fibrous and antrum before it goes into the duodenum. So the classical concept or the mechanism of action of dyspepsia is the neuropathy which leads to
failure of the receptor relaxation of fundus. So that is where the prokinetics and the classical one which is marketed very highly today, which is the cochiamide, and the other ones like metoclopramide, they play a role. Metoclopramide में anti-emetic action D2 antagonist की वजह से आता है, prokinetics का साथ में भाई है. So prokinetics are not classical treatment of GRD, they are treatment of functional dyspepsia. With PPS, मतलब EPS वाला नहीं, जो functional heartburn वाला नहीं, post prandial distress syndrome वाला. मतलब मैं academic बात कर रहा हूँ सर. आप GRD में दे सकते हो कोई दिक्कत नहीं.
Many of the patients are taking both, and they are prescribed by the experts like you. I just wanted to know if there is any specific indication.
So I don't know specific indication academically, and you can give them both because these patients can have an overlap. Practically, they can have an overlap.
Yes, sir.
Shubham, we say that GERD is a common cause of asthma or cough. Is it possible that patient does not have these burns, heartburn or symptoms of throat gush, and still you can say that the cough is due to GERD?
Yes, sir. It is possible and it is seen. It is mainly due to the micro aspirations which happen during the night. So the reflux is not significant enough to cause esophageal injury, but the lung epithelium is that sensitive that can cause the interstitial damage or the airway damage to cause asthma. It is seen that without endoscopic evidence of GERD, but with pH monitoring 24-hour, you find acid reflux in patients who have extraesophageal extraesophageal GERD like asthma, and no endoscopic evidence of damage to the esophagus or the oral cavity.
How will you say that this patient is having microaspiration? He's just having cough and asthma.
Sir, to prove that you will require 24-hour pH monitoring.
How will you suspect?
Sir, actually it is suspected by you people. You people who actually suspect. Yeah.
One examination of the dentist, a dental erosion also may help examination.
So asthmatic patients, but majority of the prescriptions of asthmatic patients are on PPIs. Because they are, a lot of times the GERD is not clear because patients who are on zero flow, the inhalation steroids, they can also have that GERD induced by the inhalation steroids. So it becomes a grey area. So, and these patients are already on PPIs, so it becomes grey. So to actually classify that this is only due to GERD becomes a little tough. I hope I am being clear on what I am saying.
Dr. Bangla and Dr. Shubham, do we have any data globally or from India on what's the percentage of LPR, laryngopharyngeal reflux, in GERD patients? Do we have that data anywhere?
I don't have. I was just wondering if the patient is not complaining because the most often the cause of asthma is allergic, weather related, may be persistent in many cases.
आप भी पढ़ाते थे ना pulmonology में extrinsic asthma and intrinsic asthma.
I was wondering if the patient is not giving and the most common cause of this seasonal, then unless patient is telling their throat rash or only then you will suspect. The second thing is Dr. Chauhan was saying that once PPI is always PPI. You see, patients who are coming to me, they will say, Doctor, gas की दवाई जरूर देती हो। मैं क्या क्यों इसको छोड़ के भी देता हूँ? नहीं छोड़ू तो दिक्कत हो जाती है। तो मतलब is it that addictive?
Psychological addiction, because these patients are not classical GERD patients, they are functional dyspepsia patients who have stress, anxiety, and a lot of patients in your practice, in my practice, in such practice are not ready to accept that they actually have issues which relate to the gut-brain axis, which require maybe a benzodiazepine or a SSRI more than a PPI.
Dr. Sushruta,
All PPIs are working through that.
No, they are not. That is just a psychological addiction there.
Not that. All PPIs are getting absorbed through the duodenum and come.
Yes, sir. Yes, sir. That is the mechanism of action.
Dr. Shubham, personal experience share कर रहा हूँ. How do you distinguish between retrosternal burning of cardiac origin and of gastric origin? I tell you, मेरे साथ क्या हुआ था कि मेरे को जिम का मेंबर बना दिया. मैं 6 महीने गया नहीं, घर में गालियाँ दे रहे हैं, महीने नंबर के मैं ट्रेडमिल पे चढ़ा, मेरे को सीवियर रेट्रोस्टर्नल बर्निंग में मैं उतर गया. मैंने दोस्त को फोन करा, मैं कल बॉम्बे जा रहा हूँ, परसों आऊंगा मैं, मेरी तू एंजियोग्राफी का टाइम लाइन ले ले, सेट कर ले, मुझे करानी। मैं अगले दिन बॉम्बे से उतरा हूँ 7 बजे, 8 बजे घर पहुंचा हूँ और सीवियर रेट्रोस्टेनल बर्निंग। घर में कहने के बाद बड़ा पाव मिर्ची का खा लिया होगा, ये कर लिया होगा, दुनिया भर का एंटीसिपेंसिड ली, लेकिन वो जो मेरा हुआ था ट्रेडमिल वाला, उसने मुझे वार्न कर रखा था। मैंने कहा साले को डॉक्टर शर्मा को फोन कर, मैं एनएचआई पहुंच रहा हूँ, मेरे को इमीडिएट। रात को 12 बजे मैं खुद ड्राइव करके वहाँ पहुंचा हूँ। सुबह एनजीओ हुई, 99% ब्लॉक एलईडी, मेरे को स्टेंट लगा और उसके बाद जो है 6 महीने से साल के बाद मुझे बिल्कुल सेम पेन, जो मुझे एंजाइना की पेन, सेम पेन, पर वो कार्डियक ओरिजिन नहीं थी, वो रिफ्लक्स की थी, क्योंकि मैं कई बार ये एस्पिरिन खा लेता था और मैं पेंटोसिड खाना भूल जाता था, तो उसकी पेन थी। तो डिस्टिंग्विश कैसे करें दोनों?
तो सबसे पहले every patient who's having an upper abdominal symptom is recommended an ECG, right? So that is very clear. If you have exertion and symptoms are occurring on exertion, like with you on a treadmill, then I think that is very classical of a cardiac thing and should be taken up very seriously. अगर आप सीवियर एपिगैस्ट्रिक पेन की रीडिंग में जाएंगे सर, तो उसमें भी इंफीरियर एमआई आता है। तो इन सब पेशेंट्स को हम जीआरडी की बात कर रहे हैं तो हम वहीं पे हैं, बट आप बिल्कुल ठीक कह रहे हैं। I agree completely that any patient with retrosternal burning also should be advised in ECG from our end.
So Shruv, if all of you guys permit me, and I have often related that incident of mine to all of you, it's impossible to distinguish this pain, CAD versus this thing. I had a massive atrial wall MI in 2003. I never got chest pain. I only had a discomfort which arose from my umbilicus and came to my epigastric region. For 5 days, during that time, I must have done at least 50 ECGs for my patients, even for those who complained of knee pain, but I never did my own ECG.
Doctors are was patient.
When in the night of 1st July of 2003, that pain started from here and then started going here and then completed the arm, I realized that it is not esophagitis.
Absolutely.
It's not esophagitis. It's something more than
Why
that.
did you think of esophagitis?
And because the pain was only coming from here and going till here.
But it went to your...
My wife had a posterior circulation stroke and I thought I am the last person who should have an MI on this earth. I am not entitled to have an MI. I am supposed to look after my children. Why should I have an MI at the age of 42 years? So what I am saying is that the question that you ask is very important. Unfortunately, there is no simple answer to the question you are asking. The symptoms can be very confusing. They can masquerade. Esophagitis can masquerade as MI. MI can masquerade as esophagitis. So please do not be taken in by anything. We welcome Dr. Vishu Basin and thank you for the wonderful CME. I would go back to Dr. P.K. Mangla sir. What I am saying is, you have pain starting from here, coming till here. Do not think it is esophagitis. Do not think it is Gerd. Please get an ECG done. You might save your life. You might save somebody's life. You might save your patient's life, your brother's life. Get an ECG done. Any epigastric pain, get an ECG done. Simple.
Particularly over
एम्बलाइकल से ऊपर कोई वेन हो उसमें ECG कराना है।
just a small comment.
Yeah.
You know, if you are getting this Gerd out of the blue, you've never had it, I think thinking to be cardiac, and if it is not getting Gerd.
That's very well.
I would now give it to Dr. J.P.S. Tulsi sir. Doctor, yeah, sure, sir. 2 words, sir.
Thank you, Dr. for a lovely talk. That's what what Sushil said. We always remain in denial mode. That means that we don't have any cardiac. A denial mode should be avoided. Appreciate the symptoms in the way it is presenting and react to it.
Repeat.
Very well talked. Lovely comments. I think what we talking about the gastritis or Gerd or symptoms of cardiac, we remain in denial mode. We don't accept it to be cardiac. So as Sushil rightly said, can evaluate in the right perspective that it could be cardiac and procedure. But again said by Dr. Mangla, in the first time you have GERD, it can't be GERD only. GERD is a very long-term process. And lifestyle management, small frequent meals, regular exercises before you start PPI is a clear good one. Anyway, over Dr.
Teachers like Dr. Chavan would not have any, this thing doubts about distinguishing between cardiac pain or non-cardiac pain. Let me begin by saying, Dr. Chavan, what a wonderful talk once again. And approximately 80% of the patients have a recurrent but not progressive form of GERD, which respond to pharmacological therapy, but identifying those 20% of the patients who have a progressive form of the disease is important because they may develop complications like strictures or Barrett's esophagus. So, why I am saying is that because surgical treatment should be considered at that early stage to avoid serious complications here. So what do you say about that?
Yes, sir. So there are clear guidelines for that. If suspected Los Angeles grade D esophagitis or grade C, you should biopsy the lower esophagus. And if you have any element of lower grade dysplasia, this patient should be offered an EMR, which is endoscopic mucosal resection. And if this patient has no dysplasia, only medical therapy, and high grade dysplasia, patient should be offered surgery.
Absolutely.
So these are the classical recommendations of the American College of Gastroenterology as well as the Indian Society of Gastroenterology, and they are very clear and we should be following that because you are absolutely right, these patients develop adenocarcinoma of the esophagus at a pretty fast pace.
So, Dr. Kalra dwelt a little about the role of prokinetics. Long-term use may have serious, even potentially, fatal complications if you prescribe prokinetics, and should be, normally, usually discouraged. The prokinetics spends should be discouraged in such patients. And you talked about surgical care and Nissen fundoplication, whether it's laparoscopic or open, is the modality of choice here for patients who do not respond to their PPIs. So let us talk a little about testing for H. pylori. See, antibiotic sensitivity has been recently, advanced in clinical practice and has grown beyond the culture and sensitivity today. I am referring to the molecular technology today. So PCR and culture, it's gone beyond culture. So PCR probably sensitive, including the molecular technology that identifies H. pylori gene mutations. See, we know that majority of the antibiotics like clarithromycin, levofloxacin, resistant to H. pylori. So let's talk a little about what, this is not what I am saying, it's talking about the American College of Gastroenterology, as Dr. N. K. Gupta would say. So talking about antibiotic resistance here, sir, just a word on antibiotic resistance and molecular technology beyond the culture sensitivities.
So antibiotic resistance is for H. pylori is real because of the
It's real
because of the overuse of antibiotics, and that is why the older drugs like colloidal bisphosphonates and metronidazole are much more effective in patients who are not responding. Sir, not going too much into detail about the genetic testing, but there are a few genes which are recognized in H. pylori for classical resistance to clarithromycin as well as amoxicillin, and they can be tested in research centers for the better evaluation for resistance to these antibiotics. But I would still say that H. pylori positive does not mean treat H. pylori. A patient ideally should have at least a gastric or a duodenal ulcer, if not a gastric lymphoma or a gastric carcinoma to be treated for H. pylori. So mucosal breach of more than 5 mm would be classical for me to actually put a patient on strong antibiotics like amoxicillin and clarithromycin.
So, Dr. Shubham, how often do you see mold, or how often do you see gastric adenomas here in chronic H. pylori infections? Mold and what do you do, sir?
Sir, very what do you call
Mold.
appropriate and amazing question. So with the advent of PPIs, amoxicillin and clarithromycin, moldoma like mold lymphoma and H. pylori induced gastric carcinoma have almost been eradicated. Right? That is again a positive of overuse of PPIs, amoxicillin, clarithromycin. Right? If you today talk about the most common malignant lesion in the stomach, it is a peripancreatic malignancy going into the stomach.
Absolutely.
Right? So that is very important to understand that primary gastric adenocarcinoma is not that common as it was 20 years ago, 25 years ago. Today, a local invasion of a CA pancreas or a CAGB or a cholangio is more common.
Absolutely. So, Dr. Shubham, talk about, if any one of us is using a PPA for a long time, many years, how common is gastric polyps seen here or gastric carcinomas, long-term PPIs? Is it common?
Sir,
What I'm saying is recently,
the long-term PPI used in
malignancy
No, sir.
or gastric polyps, recently,
Hyperplastic polyps are seen only in PPI use, but they are not.
or prolonged use of PPI strains, gastric polyps are seen.
So hyperplastic gastric polyps, they are not premalignant, they are purely benign. There are three kinds of gastric polyps that we see: hyperplastic, fundic gland, and adenomatous.
So what do you do?
Only hyperplastic polyps are seen.
What do you do with the polyps?
Sir, ideally you biopsy them, you identify the hyperplastic polyps, and you don't need to do anything.
You stop PPIs?
You should.
Thank you, sir.
Nice, Dr. Tulsi and Dr. Vatsya.
I would request my friend, my brother, and my moderator, Dr. M L Kalra sir, to please interject with his words of wisdom.
So, we had a very nice and very exhaustive interactive session. Just to summarize, Gerd, very common. If no red flags, as he simply said, 4 red flags: weight loss, anemia, even elderly, this is also a red flag, and not responding usual. So if they have a red flag, you directly have to send to Dr. Vatsya and his team, because they need further investigation. They can't be given PPI only. Otherwise, you can start with PPI once daily, 6 to 8 weeks, no response. You may continue once more, give one more chance, no response, then refer to Dr. Vatsya. This is the take-home message. Thank you.
Dr. Shubham, apart from Fortis, being director of gastroenterology in Fortis Basarpuj, any other place where you are working?
Yeah.
So I'm just working at my clinic in the evening. It's on the Shivalik Malware Main Road. It's right along with the popular unicorn iPhone showroom, the B9. So my clinic is B11. Right on the main gate, right on B9.
How does a routine endoscopy cost at your place?
So routine endoscopy at our place costs around rupees 4,500. If there is no biopsy involved, so that is the cost of
Biopsy, which biopsy?
the biopsy is at 1,200 for the lab.
And to be done, sir, H. pylori.
H. pylori is generally it depends upon what we are doing. If a biopsy is done or rapid urine test is done. So that differs, but endoscopy costs.
Alright. And are you doing colonoscopy also at your Shivalik place?
So
How much does it cost? Routine colonoscopy.
So I know colonoscopy, as a colonoscopy costs rupees 8,500, and we do a fibroscan, which is again a machine which comes to our clinic daily. So we do these diagnostic procedures there. I also do the endoscopic ICL ligations, some polypectomies at my clinic. Yeah, and fibroscan is a rental machine, it costs 4,000.
If I have a poor patient, are you open to doing a free consultation and even a free endoscopy? Yes. मैं बताई भी है, लेकिन क्योंकि डॉक्टर कालरा साहब मॉडरेटर हैं तो इनको सर्कमवेंट करना होता है कई बार
और कभी कभी जरूरी होता है।
और पीडियाट्रिक अगर वो लेना है, अगर पर्सपेक्टिव लेना है तो शरद गोपालन को सामने बैठाना होता है और फिर सामने बैठाना होता है। आई वुड हैव द फाइनल वर्ड फ्रॉम शरद एंड देन वील वाइंड इट अप।
Hello, it's been an excellent session. We have had a wonderful discussion. The whole idea was to provide a balanced viewpoint. The guidelines are very clear. All the guidelines, pediatric or adult, mention PPI as the first choice of treatment of GERD, undoubtedly. But where there are side effects which are being mentioned, please use judgment and decide whom to put on PPI. Every child with constipation, please don't put on PPI. Every adult with abdominal pain or gas, don't put on PPI. So that's the general message. Choose the patient judiciously, and PPI undoubtedly for GERD is the frontline agent. There may be some situations where you may need to use PPI with a sodium alginate, where PPI alone is not working. That Dr. Shubham is well aware of, and but those are selected cases. So by and large, we've had a wonderful discussion. Thank you very much, Dr. Sushil, for steering this whole event today, and Dr. Shubham for a wonderful job.
I would ask Dr. M L Kalra sir to please come here. We need to felicitate final guest. Dr. Moderator sir, can you please come? Please call ma'am. We would like to felicitate her.
So at Delhi traffic, they take 2 hours from IT Sainik Farm to reach here. Here, madam. So, see, Dr. Professor Jishan Ahmed, HOD of Medical College, Assam Medical College, Dibrugarh. Please.
चौहान सर डॉक्टर कालरा सर हैं। I would request ma'am to please stay here, and I would request Rakesh Sharma ji with his entire team to please come here. We would like to have a group photograph.
Sir, can you